recorded the last one, so we'll share that out as soon as we're done, or as soon as it's ready. So thanks everyone for joining us again today for our third Learning Lab. Today we're going to do something a little bit different, which I talked about when I sent you guys an email yesterday. So what I really want to talk about today is more around challenges and successes that you've had when if you've gone out and started using the tool. Anything that you're hearing from the GPs, if you're hearing anything from divisions. We're not actively marketing this to divisions yet, but we will be down the road once we get through our PSA. So that's kind of how we're going to go. We have had some more feedback around the cheat sheets and all of that kind of stuff as well, and I think Bruce is on the line too, so we can talk a little bit about those as well and sort of what's happening with that. So what I wanted to start out with too is reviewing a few things around the compensation, the timeline, the proof of concept communities, that kind of stuff. So we'll start there and then we'll move into more feedback and sharing. So I wanted to let you know to start off with that there was a letter that came out from GPSC to divisions and GPs across the province on, I think, Tuesday, that really outlined, it was the first one to outline sort of their message. It was the first one from GPSC since the strategic direction came out in April. So it goes into quite a bit of detail around what the vision is, what the patient medical home is, the primary care home, the main streams of work, and a little bit into proof of concept communities and next steps. So basically what they've said in this is that GPSC is very much taking a leadership role with the patient medical home, and they're committed to providing the tools and resources to support GPs in their practice, working with the divisions to make sure that they have capacity for leadership and coordination, and that GPs are feeling supported and connected to the provincial strategy and the direction. So they've got a couple definitions for the patient medical home and the primary care home. It's the same sort of thing that we've heard before. So the patient medical home is defined as a family practice where patients feel most comfortable to discuss their personal and health concerns. So this includes the most responsible provider, which is usually the family doctor, but sometimes can be a nurse practitioner who works collaboratively with a team of health professionals, either within or linked to the practice, to deliver longitudinal, comprehensive, and coordinated care for patients. So and then that has the 10 attributes that were released by the College of Family Physicians of Canada. So that's the patient-centered care, personal family physician, team-based care, timely access, comprehensive care, continuity of care, information technology enabled, or EMR, education, training, and research, evaluation and quality improvement, and internal and external support. And then, of course, there's those two additional attributes of the patient medical home that GPSC added, which are the family practitioner network supporting practice and family practitioner network supporting communities. Then they go into the primary care home, which describes patient medical homes or networks of patient medical homes linked with the health authority and community agency primary care services. And together those form the foundation of a coordinated system of primary and community care within the community. So, and then this team-based approach also includes other health professionals working together with family doctors forming networks of care. So we know there's a lot of overlap between the patient medical home and the primary care home and the work that goes along with that. So GPSC also identified two streams of work. So the first stream being the patient medical home and primary care home and primary care services. So this is really what GPSC is stepping into the space to lead. GPSC and the divisions of family practice together will support physician practices to enhance patient access, build practice capacity, and improve quality of care by working with them to adopt the attributes of the patient medical home. And of course, we fit under that umbrella with GPSC. And this includes a lot of work around identifying and refining the design of the patient medical home, the approach, outcomes measures, support, co-leading and developing provincial policy and direction for community systems of care, providing leadership direction and support to divisions of family practice, and things like that. So the second stream is the specialized care services, and this is the piece that the health authorities are really leading and working to integrate the health authority, public health, community services, specialized services to better link into the patient medical home and the primary care home. They do talk a little bit about the proof of concept communities, so I know there's been a lot of talk flying around with the proof of concept communities and who's a proof of concept, who's not a proof of concept, who's not a proof of concept but wants to move forward. Do the proof of concepts know who they are and what that actually means for them? And what's happening is that GPSC, a lot of this has come out from the Ministry of Health, and GPSC is really pushing back on this and saying, well, we need to decide on these proof of concept communities together, and then we're going to go out together and have discussions with them to explore the work that was done in the past, the work that's happening now, understanding the supports that they need to enable and support implementation of the PMH, and really to talk about the role of the divisions in the work. So what they've said in this letter is that as these communities are identified, this is what's going to happen. They're not naming communities, and that's something that's going to start happening throughout the end of September and into the fall. Okay. And also, the GPSC is going to be really focused on the provincial approach to implementation of the primary medical or patient medical home and primary care home, concurrently with supporting the proof of concept communities. So we will support the proof of concept communities as they're named, but there's also going to be a whole provincial approach to help everybody start moving in this direction, which is really a lot of what we've been talking about in the last little while. So around the next steps, what GPSC has outlined is that current work includes working with the divisions to clearly understand and implement the resourcing need to support both the proof of concept communities and the broader provincial patient medical home implementation. Working with us at PSP to refine and direct service in keeping with that strategic direction, and working together to better define the role of the divisions of family practice work. So that between the divisions and between us at PSP and all the other groups that are supporting this work, we're not stepping on each other's toes. So by November, they will have defined specific resources and supports for practices and divisions, and they're having a provincial event November 27th and 28th where they're going to have a deeper discussion about how they're going to move forward together. So it's really, they've come out and really, stepped into this space, said, okay, we're leading this work, and this is how we're going to go forward. So it's really good for us. We're in a really good place right now with the plans that we've put together around the tools, the new small group learning sessions that will come out, and all of that. So I want you guys to feel good about this, because we're, as we're testing this and moving forward with these tools and everything, we're really, setting the stage for ourselves to help support this work to move forward. So does anybody have any questions or comments about that before I keep going? No? We're good? Okay. I'm going to carry on. If you do have questions or anything, totally feel free to send me an email or give me a call later today or tomorrow, or whenever it pops into your head. Okay, so I also wanted to talk a little bit about the compensation and the timeline. So I know there's been a lot of confusion about the compensation, who are, our 5 GPs per division, how is this going to work, is that what's going to change when we roll this out more broadly, like all of that kind of stuff. What I really want to emphasize is that the compensation as it's set right now is very much part of the fact that this is a PDSA, and we developed this tool and had no idea how this was going to work, and we need to make sure that we're compensating those doctors who are helping us with this appropriately for their time, because it's a pretty significant chunk of time. So that compensation will change when we move and start rolling this out more broadly. Now, in terms of timelines, we won't be rolling out more broadly until we really finish our PDSA cycles. And so I think with this first panel assessment tool, that's probably going to be around the end of September. But we are, we do understand that there's been a lot of challenges with the cheat sheets and with the EMRs and with the process. So to go along with that, we are exploring different opportunities with the EMR vendors to try to understand if there's something different that we can do that would make this whole process easier for you. Ideally, that would be a canned report similar to the objective data dashboard maybe, where when you go into a practice, it doesn't matter what EMR it is, the MOA or the GP can hit a button and it's going to spit out all of the panel assessment indicators for you. But we don't know yet, and it's really early stages in conversation. So right now we're going to carry on with our cheat sheets, and whatever, whatever feedback you have from those, we definitely want to hear it. So it's great to keep hearing that come back. Questions around compensation or timeline?
Hi, Leah, I have a question.
Yeah, go ahead.
So they get funded for the initial assessment, and then there's another sessional available for showing change. Is there any parameters on how much the indicators need to change, or what to occur to be eligible for that compensation?
That's a great question. I think that ideally we would like to see. Great, guys, I'm getting some feedback, so if you're not on mute, would you mind on mute? Okay, there we go. Thank you, that's got it. So ideally what we would like to see is that sessional for the work that they've done to clean it up would be when their panel is actually clean. And I know for some doctors that's a lot more work than others. It really depends on how diligent they've been in using their EMR and using things correctly. So I know that it could be a huge amount of time and effort to do that, which is partly why we've included that compensation for the MOAs as well. Yeah, that's a really good question, and I would like to see it come out when they've actually, they've actually done the cleanup, because we don't have it set up so that you can get a sessional for, you cleaned up your first few panel indicators, but the rest are still a mess. It does need to be when it's looking like it's actually up to snuff.
Leah, it's Bruce here. Could I just add in a comment there?
Yeah, of course, Bruce.
Yeah, I think that's a great question, and the answer to that sort of depends a little bit on how we're approaching this. If we're approaching this from the old pedo viewpoint, there was a target, people had to achieve that target, it was very QA, and if we're going at this from the spirit of QI, that we're looking for improvement, the idea is that there is no targets here, but there needs to be a sense that there's been an improvement. And to be able to do panel management, which is the next step, where you're actually working with registries of patients, you really need to have things cleaned up to the point that you have a pretty good idea what your panels and various patient registries are. So it's a soft land in saying, you're at that point that both the coach and the physician say, I think I've got a pretty good handle now on who my patients are, which have hypertension, and so forth. to be able to sort of say, yeah, okay, that's accomplished what we need to accomplish. And that's sort of in the spirit of more being improvement rather than let's set a target. Now we're at a point we can work with what we have.
So that's a really great point, Bruce, and thank you for framing it around that way. So I have a tendency to think in hard and fast targets. Where is that something that you think the coordinators and the coaches should really just use their own judgment, or do we see that in, you know, at least do we frame it in that some of the panel indicators are looking like they're cleaned up and they're feeling comfortable and moving on?
You know, I think the key to this is that nobody's going to get it perfect right from the start. And looking at things, and some questions have come up around identifying patients with chronic pain, identifying patients that are eligible to start having the advanced care directive conversations, identifying frail elderly. There's going to be a lot of work that's necessary once you start understanding, but what we're aiming for is a starting point, that baseline that we're ready to start now saying, okay, now we've cleaned things up to the point that we're ready to start trying to figure out how are we going to identify all our frail elderly, not starting from the point where we've already got all our frail elderly identified and we're ready to go.
Okay. So does that help answer your question? It's a bit
yes,
of a
thank you.
Okay, great. Any other questions?
Aaliyah, this is Jenny. Can you guys hear me?
Yes, Jenny.
Hi. I just, I think like that was really great comments and thinking through that. I feel like as the important thing we probably need to consider as we move forward learning about how we're going to do this, but to Bruce's point, maybe we could provide some guidance about not hard and fast targets, but as learning from you guys, and then at PSP Central we can kind of think through what that trigger for that second sessional would look like, with like a kind of wide set of parameters around it, so it's not, you know, making anyone feel like it's an impossible kind of thing, but it's in the spirit of helping, supporting you guys to be able to more objectively make decisions about when that second sessional should be paid, and that's going to be true of part 2 of the tool and part 3, and then as well. So I think we can work towards maybe providing you guys with a little bit of guidance on that for sure.
And Jenny, one of the points to that in providing prevalence numbers is that gives you that little bit of gauge to be able to look at a practice. If it's got an average demographic to the province, if someone's prevalence of, say, hypertension is only 3%, we know out there in the real population that the prevalence should be somewhere around 20 to 25%. So there's something missing. And that's a key to work on. So if you're going to use anything to gauge the readiness of the practice to start looking at their registries, using the prevalence as that gauge is a good way to go. Not a target, because every practice is different, but using that to sort of be able to judge. And that's ultimately where we're going with all this, in that any practice in anything you're doing, we will have the ability through being able to use the Health Data Coalition tool to be able to look at the practice in context, in comparison to other practices, other groups, or the whole province. And that'll be able to help people quite a bit more. For now, the hard numbers we give you with the prevalence that are part of the spreadsheet will be quite useful for that.
Okay, thanks, Bruce.
And guys, there's just one other thing that I want to add to that, and Kelsey just mentioned this to me too, is that while we don't have there aren't those targets right now. It could be that down the road, as part of patient medical home implementation, GPSD starts setting targets, or the incentive working group starts setting targets. So while we don't have something right now, and we'll start working through this as we go and figuring out where sort of the guiding principles around that should be for now, it could be that will change down the road. One of those, is part of the evolution of how the patient medical home is going to come to be and how we're going to support it. Other questions?
Hi, it's Denisa calling in.
Hi, Denisa.
Hi, I kind of have a question about, it's not really in terms of the compensation, but more about, this whole panel cleanup. I'm doing a work that's related to neighborhood networks in Richmond, and it's a very similar setup to the patient medical home. And what I'm doing with this group of GP, I've been helping them with deactivating patients for people who haven't been seen at a specific number of years, so 2012 or earlier. And what has happened recently that has come up was the EMR that they have, which is IntraHealth, it's been counseling patients who are future booked. So basically, when you're deactivating patients, if there's anything in terms of if they have any outstanding interventions or open referrals, or even deactivating patients who have a future appointment booked, there's an alert that's to come up to prompt it to stop me from deactivating the patient, because essentially it deletes the patient's appointments if they were to be booked tomorrow. So I'm actually wondering, in terms of this, because it's been brought up to my attention, is there, how would you take this on in terms of, any flags to catch this? Because I don't really know, in this sense, what are we supposed to do, and, if this was to come out in any other EMR, is there any way that we can, as an advisory, how we can just, prevent this from happening?
So, Denise, it's Bruce here.
Yeah.
I think there's a couple comments to that point. Number one, that's revealing an issue specifically with an EMR function that is one that needs to be flagged to the vendor, because that should never happen. Just because you change the status of a patient from active to inactive should not affect future transactions with that patient or flags. So that's a great thing to have identified, and email that to Aaliyah and Kelsey, and Kelsey can work with Bridget to identify that to the vendor as something that needs to be worked on. So that's one point that's great to identify. So this is exactly why we're doing this kind of work, because we're going to stumble across things like this that the vendor should be aware of. The second is, this points out a key message, something that I mentioned last time, is that whenever we're generating a list of patients, to apply to do something to the EMR in a batch. So we're changing somebody's status, or a whole list of patient status. We're sending a whole list of patients to task or so forth. When that list is generated, it's important to take a look at it and make sure that nothing is done to any one patient that can't be undone. So for most EMRs, that's not an issue. Even if you apply, say, a test request for a hemoglobin A1C to be done to all diabetics who haven't had one in 3 months, you can undo that. But what you've just described is something that you may not be able to undo easily, or that you may lose. And so it's really important that when you've identified a process that isn't undone easily or has consequences, that it's up to the coach and the physician to look at that list carefully and make sure that every name in that list is appropriate for that task or process to be applied to. Does that help you?
Yeah, it does. Okay, I'll email Aaliyah and Kelsey about this.
Yep.
Yeah.
And
Thanks,
then
Bruce.
we can deal it from there.
Okay, sounds good. Thank you.
Thanks, Anita. Other questions? No? Okay. I think that we will move on. So that's pretty much what I wanted to kind of cover off with you guys this morning. Oh, does somebody have a question? I can just hear some background noise. Can you guys just make sure you're on mute, please? Thank you. Okay, so I think from here then what we'll do is I want to just open it up to all of you. So I know that some of you have had a chance to get out there and start trying out the cheat sheets, start trying out the tool with some of your GPs who are keeners or who you have a really great relationship with. So I think it would be really beneficial for us at Central and for the group overall to hear more about sort of what approach are you taking with them, how is it going, what's working well, what's been really difficult. Are there challenges that you're really struggling with that maybe it's something that we can work through together and come up with a way to approach it. So I think with that, I'm going to open it up to the floor, and please don't be shy about jumping in.
Aaliyah, maybe I could start with just a couple of things that we've heard so far,
Sure,
just to make sure and see how they resonate with people.
Yeah, go ahead.
So there's been, and thank you for those people that have sent emails and comments in about the process. It's great to see people sort of diving in and taking it with a spirit that we're learning something here as well, which is great. There was a comment, I'd be specific about just a couple of the EMRs. There's a comment about Wolf that it turns out that in many of the EMRs, if not all of them, the objective data dashboard may have been turned off in the system for people. And so Kelsey and I have connected with Wolf about that, and we'll look at possibly turning on those features of the objective data dashboard that relate to the first 5 questions around the demographics in there. We've also, so that was with Wolf. With Oscar, there was some question around the actual queries and how you ran them. And there's a suggestion that the solution, some of the solutions that we've offered may be more complicated than they need be. And I'm looking into talking with one of the technical people with Oscar to see if we can't streamline that a little bit more. With InterHealth, certainly found out that the objective data dashboard has been turned off because it's too resource intensive and takes too much bandwidth and runs too much time. But in conversations that we've had with the technical people, they're offering or suggesting some workarounds, and Kelsey and I have spoken with them about being able to develop some different instructions that work through a different feature of InterHealth that may be useful. So I think, Kelsey, those are the 3 different EMR specific things that we've run across that we're having to attend to right now. I'm not sure if you had any others that you were aware of or something that I've missed.
No, thanks, Bruce. That's an accurate summary. Thank you.
Hi, Bruce. It's Jillian Wong. Just with respect to IntraHealth, I had a clinic try to run the dashboard. So when they called the support desk, they weren't familiar with the term dashboard. So they used the term key performance indicators. So when she phoned back and asked for the KPI to be run, they were very specific as to which indicators they wanted run. So I think that's something that needs to be resolved as well.
Okay. We use dashboard as the terminology that came from Keto. So there was objective data dashboard, ODD was used with them. So, but that was some time ago. There are some terms that are ubiquitous to the industry. Scorecards, dashboards are things that are used as terms out there. But certainly what you just mentioned is key performance indicators may be something that people think of, and being able to speak a standard language to any of the vendors so that they know what we mean is something, that's a good point. So maybe what Kelsey and I can work on is talking with the vendors to sort of make sure that we get a common language and that's produced in some kind of a handout so that you know when you're talking to vendors, or they know when they're talking to you what it is we're talking about. Great point.
Bruce, it's Erin. Do you have a rough ETA when IntraHealth might be up and ready?
Kelsey, over to you on that one.
Yeah, no, we don't. We're actively working with, a few of the vendors right now on getting just sort of an outline of what is possible. And just further to everything that was just sort of covered off there about kind of producing better instructions or documentation of instructions, we're actually also exploring and, with them what might be some better solutions to streamline this for clinics. So we're definitely inquiring about options for new canned report. So call it a dashboard, call it a widget, call it a canned report. We really want to, at this point, understand what would be the easiest path in each of the EMRs to get this information at the fingertips of the practice and yourself.
Can we have the timeline sent to us as soon as we know? Because obviously for us with some of the communities, we need that like as soon as possible.
Yeah, we will. I mean, I will be communicating as soon as we have it. But I mean, the messaging or the sort of the timeline that we're communicating is as soon as possible. We know that a lot of them will be able to leverage some of the functionality that they had from the objective data dashboard. So in preliminary conversations, I've not heard anything that suggests it's going to be like months away. I think that most of the companies at this point are probably thinking that they can help, deliver something in sort of the, kind of the mid-fall. So I'm thinking 4 to 8 weeks is realistic for us to start seeing things available. But I'm hesitant. We will communicate with you guys via email, and please, take what I'm saying here as a grain of salt because we don't have anything contractual yet. So as I see it, there's sort of two streams of work. We're trying to get feedback and improve any of the documentation we've provided in the cheat sheet, so to speak. We're also trying to have conversations about what can we do in partnership with the vendors to provide easier solutions for running these types of reports. So there's two things happening.
Hi, it's Candace from BCH. Just speaking to reports, we have a number of clinics in our area that we're working with on Wolf, and in practice search, we've come across an issue that exists in all the clinics we're working with doing data cleanup, in that when you open up practice search, it defaults to active only, not deceased. But when we're running searches, patients are showing up on lists who have been inactivated or marked deceased. So, we go in and double check the chart and make sure that the status has been changed appropriately, but we are just manually scratching those people off the list and doing a recount, knowing that Wolf is working on it, and they've come into a couple of the clinics and they're, you know, checking out what the issue is, but just to be mindful that maybe your clinic or your physicians or staff are changing the status. It's just not accurately reflecting on practice search sometimes.
Candace, it's Kelsey. Could you, any emails that you have about that, or if you could just send me a note just summarizing that? It's really, really helpful for me as you guys are out there doing this stuff, encountering challenges. If you could just keep me in the loop, because that helps me in my conversations as we, you know, work with the vendors to produce, you know, accurate documentation. Because I think part of it, like I was listening to the previous question about, I think I heard deleting, not deactivating. And so I think it's really important that we get the vendors involved in creating the supporting documentation, because sometimes it's a matter of just, you know, not maybe knowing how the function or the feature works. So, but yeah, if you could forward that to me, Kenneth, that would be great. I also just wanted to point out, I'm sorry, Bruce, I was remiss with adding something. We were contacted by someone who has 2 clinics that they are supporting in Practice Solutions, and they were just inquiring about would we be developing any cheat sheets for Practice Solutions. So that's also on our to-do list, and also one of the pieces that we're talking to the TELUS Health team about. I know it's not necessarily one of the most common EMRs, but there are some clinics out there that are running it.
Yeah, thanks. That's good, Kelsey. I remember that as well. And to the previous point about forwarding anything to Kelsey, the purpose of what we're doing here right now is exactly as Kelsey is saying. It's not just working with any one office to clean up their EMR. It's also to identify for us and the vendors what some of the functionality issues might be, and for us to be able to connect with the vendors to offer system-wide solutions rather than individual one-off solutions. So as you know, little things that you run across or that the vendors contacted about, it's great for us to hear about all those things. You guys are so powerful being out there, being the ones being able to connect with the physicians and offer them a process and a path to have a solution that is something that pushes their problem up to a high enough level that the vendors pay attention. So that's great to hear those kind of things, and we need to hear them. That'd be wonderful.
It's Candace again. I just wanted to share a lesson learned since I did something funky. We're working with a lot of profile people, and when you're doing some searches in groups, you can pull up a list of folks and you can do a pick list, kind of tick, 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 and en masse add a problem to problem summaries. And in profile, it will skip patients who already have that code on the problem summary. I assumed that another EMR vendor did the same thing, and so we did the pick list and add to problem summary, and it duplicated where it already existed. So we had to go back and take one of those off. So hopefully now nobody else will do that.
Yeah, you know, and there's a good point, Candace, in that if you're running a search, and what you described in the scenario where the problem was added when it was already there, that'll happen in MedAccess and Wolf, I believe, both TELUS products, so that even if something is already there and you say go ahead and add it, it'll duplicate it and add it again. No big deal, except that it messes up the EMR problem list and you have 2 hypertensions coded 401. There's the value in being able to use the NOT feature. So in, say, for example, MedAccess, you can say, find all patients who have hypertension by the blood pressure being greater than systolic 140, who do not have the diagnosis hypertension coded 401 in their problem list, or the code 401 in their problem list. So having that NOT feature as part of running the search, can be really useful in many EMRs. And it's generally fairly easy to be able to trigger that not feature in many of them.
It's Aaliyah. I'm going to jump in for a second. So there was a question through the chat around the ETA for the new Oscar cheat sheet. And Kelsey, maybe you can fill us in a little bit on what's happening with Oscar.
So as Bruce touched on in discussion with the Oscar board, and as I outlined in my email, there was an email that went out, I believe, last Thursday, right? Just in discussion with them, and as Bruce, already mentioned, there might be more sort of technical implications and challenges that we didn't anticipate, and so I think more where the conversation going at this point is how can we work with them to create, again, a pathway to get the reports, and that's looking at this point like it would be best facilitated, if that was created through sort of the Oscar McMaster group and the Delegate BC board. So we're in those kinds of conversations now. I think the note we sent to you guys last Thursday just tried to outline where some of the challenges were with the cheat sheet and where some of the risks might be. So, that's not to say that our clinics are, at a level with, using their Oscar EMR and understanding their data that they can't do that work. It's just to suggest that if you're unfamiliar, they're unfamiliar, that we might want to hold off on starting this right now until we have, better report functions that are created by the developers themselves. Does that help answer your question? I think so. Okay.
Other questions?
Hi, it's Jen Tongol here. I was just wondering, in means of the ODD and in means of this panel assessment and management tool, my understanding is that these separate, even if the ODD is running in a certain EMR, these separate conditions in means of hypertension, heart failure, diabetes, COPD, chronic pain, et cetera, they're not specifically there's not a specific functionality that it looks for in the ODD. So I'm just wondering, are we all going into these practices and using the same workflow, or would we do it like a separate way? Because it means of the way I do panel cleanup, it would be creating the query. Like, for example, in profile, I would specifically go in and create the query. So it means of looking at the ODD, that's not something I would look at. So I'm just wondering, are we following a workflow that's consistent with everyone else as an RST, like throughout the province, or can we just go in and start answering these questions in means of how many active patients they have off of the ODD and then start going in and creating queries? Like, I'm just wondering, is there, it says that we're supposed to be doing a certain workflow in means of answering these questions, but I don't know if in means of quality improvement-wise, if we're all doing the same thing, other than getting the actual answer.
Yeah, Jen, that's great. And actually, what you're doing, you have a better working ability with InterHealth than most people do. So what you're doing, we need to learn from. And so those things that you've already provided, like some of those, the instruction sheets for InterHealth, keep providing them. And when you see things that need correcting on our instruction sheets or on our flow sheet, feed them back to us. And then we'll make sure that they go out provincially to everybody so that everybody else has the ability to make use of your knowledge in a way that's reproducible and scalable. Your question about do we need to do it exactly the same way? No. I mean, the ideal thing is we want to get through those first 5 things and clean up and code all the chronic disease management. That's the panel cleanup stuff is pretty standard. It is pretty boring. There's nothing terribly exciting about it. It is what it is. And so standardizing that as much as possible will be important. The next point around panel management is much more flexible, and it's going to be much less standardized. And as everybody's skill levels increase, with being able to run the queries like you do with InterHealth, they'll have that flexibility to do things in a way that is more aligned with the principles that we're working for quality improvement, working with people to make the improvements and do the things that they want to do. So we need your help in being able to help us through those steps with InterHealth, for example, and the kinds of queries and what you've learned and what works, and then share that with the rest of the people in the province.
Okay, thank you, Bruce.
A couple other, if there's not a question immediately there's been a couple other things that came up. One was, and it's old, but I just thought it bears repeating, around the developing registries and some hints. There is a one-pager EMR panel cleanup hints that I've created that just ask some simple questions. You know, how do people identify hypertension in the EMR, heart failure, diabetes, COPD, chronic pain, or polypharmacy? So there's just some very brief little 4 or 5 points with each of those conditions that's on a one-pager that you can use to sort of say, okay, here's a way of finding a patient with this condition in the EMR. That's a one-pager. And then there's an older one-pager that was created last year for chronic pain, because that's a bit trickier. A lot of people don't have chronic pain coded in their EMR. This came up at the last session we were talking about. And so there's some hints on what kinds of patients you might search for or help the doctor with sort of saying, you know, this is a patient that probably would deserve having chronic pain coded in their EMR if they have, for example, chronic lumbar or neck pain, chronic headache, chronic pelvic pain, fibromyalgia, rheumatoid arthritis, or who are on opioids long term. So those are just some examples of searches that can be done. Ruth Ann from Fraser Health raised a really good question about finding, and this was sort of jumping ahead a little bit, finding people that were end of life or eligible for advanced care planning, as well as being able to find people that were frail. Now, we haven't jumped to that learning session yet. So if you are at that point with a physician in their practice and are wondering about, you know, just how you might go about looking for these kinds of patients or identifying them, there are some specific ways that we will hand out some information. And, or if you're at that point with somebody that you need it now, I'm certainly quite available to send an email to me and say, you know, how do I go about doing this in this EMR? And we can talk about it a bit. Back to you, Aaliyah, unless there's any questions on just what I mentioned.
Thanks, Bruce. The other thing, so Kelsey was filling me in on that a little bit too, because I wasn't aware of those sort of more generic guidelines around keeping things up to date. The other thing too is I think that that's definitely, you know, that is the next space we're going to, you know, move forward with. And there's pieces around the panel, ongoing panel management and panel maintenance that we can do. And one of the thoughts around that as well, originally we had been thinking about panel management as a small group learning session, but that would be a one-off, and it's, you know, it's an ongoing process, right? So we're thinking about that in the context of maybe something around the lines of user groups, something like that, that the GPs can do together. But yeah, we definitely want to have things in place that support them to help keep their panel up to date you know, keeping those, you know, knowing that their prevalence levels are where they should be, or if they have a more atypical practice that focuses on something specific, then, you know, they can, it's easy to see that in their EMR. It's not just that they think they have it. And we are, I think, Christina just sent it to me. Okay, and I will make sure that we share out the one-pagers that were mentioned as well. Okay. Other questions?
Ruth Ann, did you have anything else to mention that ties in with what we talked about with frailty and end of life?
Well, I guess my two practices I am working with, they're both really, they have pretty clean panels, and so we're ready to go to that stage. So I don't want to go down that path until I have some guidelines of how do we do that? Like, how do we pull those patients? How do we know what they are? I'm going to sit with the GPs and say, you know, what do you think? How do you think we should identify these? How would you do this currently? But, yeah, looking for some guidelines about kind of those next steps and how will we know, again, if we've been successful, if we've achieved it.
So I had given you a fairly general answer that is sort of where things start with that. And, you know, one of the things that, again, and I'm sort of mentioning this to everybody, one of the things that we could do in that particular situation is say, okay, let's learn from this. And you and I could exchange emails and have them connected with Kelsey and Aaliyah to sort of work away a strategy that could be tested out with these practices. And when we know exactly what EMRs they have, and be able to test it and then develop an instruction sheet, basically, to say, this is an approach that you can use with this specific EMR, and then we can see how it can be shared and spread to other EMRs. So it's a great opportunity to do something like that.
Yeah, I'm willing to do that, and I know both these practices, their MOAs are really willing to work with us on it, so, and the GPs, so certainly I can touch base with you about that, Bruce.
Perfect.
Great, thanks, guys. Other questions, or should we maybe move on to talking a bit about the approach? Like, are there any challenges that some of you might have had going out to a practice with this, and you know that you run into with the GP or with the MOA, or because we've been pretty focused on the EMR. And if there are more questions on the EMR and the cheat sheets and all of that, let's keep going that way. But I'm curious if we want to shift the conversation a little bit.
Thanks. I just wanted to say the practice that we've attempted to start panel assessment with has been so involved in being a pilot primary care home site and getting new staff trained and actually having renovations done, that's been the holdup for us for testing the tool.
Yeah, it's definitely, I think it's because we know it is something that's going to be pretty time intensive. It is, you know, they definitely have to have the time available to really start moving this forward. So it's, you know, it just needs to be when they're ready. And if they're not ready, that's okay.
This is Margie. Just wondering if there's a plan to send out something from GPSC or Doctors of BC to all the physicians so that they are aware of the direction of PSP, and to let them know what the practice coach's role or PSP coordinator role will be?
That's a great comment, Margie. So we are working on a communication that's going to come out fairly shortly, probably not tomorrow, but early next week, around what tools we're working on developing, and what's coming down the pipeline, and sort of where PSP is sitting within all this patient medical homework. Now that we finally have, GPSC has sent out that communication, we can actually start stepping into that space with our communications as well. We didn't want to be, the first out of the gate saying, this is our plan for patient medical home. By the way, you guys don't know anything about it yet. So we are definitely planning communications around this and sort of what's on offer through PSP and how we're going to support that. And I will definitely share that with all of you before it goes out to them, so that you have it in your back pocket.
Yeah, hi, this is Ryan from Fraser. I second that idea very much. I think that we had a first meeting with our prototype community a couple of weeks ago, and it was pretty clear to me that there is some distinction or a gap between their version of the patient medical home work that they're doing and, the GPSC's version of the patient medical care home. And so the idea of, we're going to come in here with tools and clean up your data, and here's the tool, what do you think? Didn't have as much traction as I might have hoped. And so I think there's actually a backgrounding piece here, a backtracking piece that needs to occur. And Aaliyah, you sort of spoke to it at the beginning of the call, that GPSC wants to step out and say, hey, we want to lead this work, we want to take it on. And I think that we've moved into the deployment and tools phase really quickly. And what I was missing in my interaction was oh, yes, we know what you're talking about. GPSC's worked with us, we've sat down together, we understand what their vision is and how we fit into it. That wasn't there. So it's actually, I think there's a step before where we're at now that we need to go back and take with the prototype communities.
Yeah, and you're right, Ryan. So part of it is a symptom of the fact that there's been a lot of conversation that has happened between the Ministry of Health and the health authorities, conversation between the health authorities, executive level, and divisions or certain doctors in certain areas, and all of that's been happening. And it's so varied across the province as to who we've heard maybe prototype communities versus which communities have actually heard their prototype communities, what that actually means for that community. So I think that with this communication from GPSC and sort of the way things are going to move forward, it's going to become much more clear for them and for us how this work is going to move forward and how we're going to support it. The thing with these two is that we're still, remember, we're still testing these. This isn't final, this isn't, our final product that we're going to roll out across the province. It still very much needs to be framed in that, this is something that we've come up with. We know that panel cleanup, like knowing who your panel is, really is fundamental to doing this work. How do you do team-based care or research or QI or anything when you don't actually know who your panel is and you're not able to pull that data out of your EMR? So we've, come out with this, and this is an option. It's something that we're working on, but we know that we're not there yet, and they're not there yet necessarily. So
no, for sure.
It's a big learning curve for all of us.
So absolutely, but that's just I don't have feedback yet on tools or what it's like to actually try and run reports, because we didn't get there. We're still in that phase before where we need to reconcile. What do you see this project as being? What attributes are you working on? How are you going about this? Versus what does our funder see us doing to support you, and what tools do we have? And, I think we need to find some kind of area of overlap between those. We need to reconcile and find an area of overlap between those two sets of expectations and ideas to really even begin work.
Yeah, yeah. And it's different in each community.
So, Ryan, just a comment from me about that. You know, part of what we're talking about here is not particularly exciting or pretty or sexy stuff.
Yeah.
And whether or not it's associated with patient medical home or quality improvement is rather moot. One of the key things that is going to change with time are some of the foundational pieces. You know, so some of the things around communications, using motivational interviewing techniques, being more patient-centric or community-centric, improving health literacy, improving the way that physicians input data into the EMRs is all stuff that needs to happen irrespective of anything else that's coming down from the top. And I think approaching it in that way, unfortunately, is a bit directive and isn't particularly respectful of the physician's choices, but it is something that is really necessary. And being able to find the answer to the why are we doing this, needs to be separated from patient medical home and all that other stuff, so that, you know, it's that start with the why and then move through the how and into the what. It's the Simon Sinek approach is going to be really key here. So being able to separate this a little bit from patient medical home and say this is just something that's going to be really important for your patients, your practice, for quality improvement, you know, whatever it is that resonates with the practice is going to be something that needs to be a step that we do. To your point, answer the why.
Okay.
Yeah, thanks, Bruce. Other questions or comments?
Hi, it's Denise here.
Hi, Denise.
Hi. I'm just actually wondering, like, how are we going to get the buy-in from the MOAs, like, in terms of helping with the panel cleanup? Because I'm assuming that, it was probably brought up in the last meeting that PSP is not going to be doing the body of work of helping the GPs deactivate the patients and whatnot. So I'm just wondering, how are we going to get a better buy-in with the MOAs? Because we hear, just going through practices, they always say, I'm really busy, I'm always booking appointments, I have to do recalls, so on and so forth, right? Like, how are we going to be able to convince them that this is a really good start to the patient medical home and, like, really encourage it to them?
So,
that's
you know,
really great.
I think the point there is what you're speaking to is why for me as an individual, why for me as an MOA, and talking about the patient, and this is the point that I was making before earlier, talking about the patient medical home isn't going to resonate particularly well with an MOA. You know, what they're concerned about is exactly the things you're talking about. The currency is about time. I'm busy, I have lots of things going on, I've got lots of jobs to do, how do I improve that? So a couple of things that I think that you use with them is, okay, what's going to resonate with them? And one is, okay, what in all this is going to make my work more efficient? Well, knowing and being proactive and being able to schedule people in a planned way that require scheduled follow-up. So all these patients that are on the chronic disease registries, preparing for visits so that if somebody's coming in and is frail, that there may be a certain questionnaire that they give out to that patient while they're in the waiting room. Being able to know who your patients are with the big 4 chronic diseases that have MSP or GPSC incentive billing, and being able to be proactive about scheduling people in to make sure that all the eligibility criteria are met for those billings is all part of the foundational work that we're doing here on panel cleanup. So being able to be specific about them addressing what's important to them around billing and time management is going to be key, I think.
Thanks, Bruce. And that's a great question, Denisa, too. The other thing, so I'm curious because I think that if I remember correctly, some of you do have worked as MOAs previously. So if there are any of you on the phone who have, I'm curious if there's anything that comes to mind for you back when you used to do that work. What might have motivated you to take this on and move it forward? All right. Maybe we don't have anybody who has a background as an MOA, or you're being shy, which is okay. That's okay. Yeah, I think that's great, Bruce. Thanks for adding that in there. Any other questions?
Hi, no, it's Jen Tongle again. I just wanted to say that, yeah, I guess the incentive would be something an MOA would like to have as well in means of an action portion of this work. But in means of the compensation, I think that's a great segue to what you were talking about initially, which was compensation. So I just said, like, as a group, we were just basically conversing and saying that, yeah, in means of getting the MOA to do the work, it would probably take that compensation in means of the incentive to start the work.
It's Adam here. In GP for me, we did some of this work and really found the incentive was getting the whole team on board, so all the doctors. And I don't know how many of you guys have office managers, but they were pretty critical in doing some of this exact stuff, and they were pretty keen and had more flexibility.
Yeah, Adam, I agree with you. It's Jen Tongle again. I just think that when it comes to the actual engagement portion, we definitely need the whole entire team, the team-based model to come in. So you do need everyone's engagement.
It's Candace from BCH. I think maybe a positive for an MOA is talking about job satisfaction, not just data cleanup, but being a little bit more involved in some proactive preventative care and being part of the searches and who's due for what and maintaining follow-ups and things like that. You know, it could enhance their job in what they do and not just cleaning rooms and answering the phone. They could participate a little bit more, and starting with that is really getting into the data cleanup and making sure the patients are active and that you're not pulling up lists of names with a whole bunch of people you have to cross off because they haven't been in forever. And, you know, I think once the MOAs get involved in the cleanup, they really start to get interested in what's happening and who are these people and what is a good proactive care plan and things like that.
And it's Jen Tongle. I just wanted to say I have an idea that maybe we could make it into a contest. So like for the MOA that cleans up the most or panels or however it happens to be, we can make it into a fun activity. So maybe that's a way of engaging the team.
And another comment there too, and it addresses that currency of time, is ask the question, how often have you tried to get a hold of a patient and it's the wrong phone number and it's the wrong address? So is there a way you could address that? You know, a little script every time you answer the phone or every time that you see the patient at the desk to say, we have this phone number and this address on file. Is it your current one? Because everybody's been involved with searching and trying to find the contact for a patient when their EMR data is outdated.
This is Margie. I'm not sure what kind of incentives you're looking at when it becomes an official thing, but I would vouch for CME, especially for physicians, because I think this potentially has the opportunity for changing practice where it's actually making a difference in the practice from what I've been participating in since the beginning of PSP, and they're always looking for CMEs, and I see this as one of the most valuable CMEs.
Yeah, Margie, I think this is something that we've been talking about centrally too, and how can we get sort of the in-practice support pieces or these tools certified and credits attached to them. So it's definitely something that we're considering and we're looking into.
It's Esther again. I'm just wondering, is there any way of connecting this to the GP's fear of being audited?
You could.
The reason I ask is, in one of our local division newsletters that has just come out, they're running a series on steps in being audited, and they also have a link to the excellent site, Kelsey, that you've put up on optimizing your EMRs. And I'm wondering if the two, they're obviously rather connected, and maybe having some of the helpful tip sheets that you've developed, Bruce, on this actual site. So it's not just us as PSP coordinators coming in and telling them the benefits of panel assessment and cleanup, but they're also reading it on the EMR pages that they're looking at and in the audit information that they're reading.
Yeah. We might be able to put some of those up on the website too. Kelsey and I will take a look into that as well. And yeah, that might be, you know, a good incentive for them to start doing this work too.
It's Bruce again, and you know, it's an interesting thing when you look at research around what motivates people to do stuff. You know, probably most people have looked at Dan Pink's work and others around motivation, and it's really interesting that incentivization or threat of punishment is not as big a motivator as you might think. It does motivate some, and it especially sometimes can motivate some of those who really are desperately in need of doing some work. But it's back to that sort of Dunning-Kruger effect, is you don't know what you don't know. So if you think you're doing fine but you don't know, you're not even aware enough of being afraid of having an audit. Well, you know, and same with incentivization. It only works to a point where, you know, I've made enough money, I don't need to worry about making a bit more. So the motivating things that are talked about is, I think, as somebody mentioned earlier around that, having a purpose. I'm doing something for the greater good of the practice, and mastery, that piece of, you know, I'm learning something here and showing my value by being able to do something for the practice that nobody's done before. And that final little piece of autonomy, you know, building to it, hey, you can do this on your own. You don't need to be told about it. You can choose what it is you want to do, and you can sort of brag about it after it's done. And I love that idea that you add that competitive flavor into it of sort of saying, and we are all competitive. You know, we're going to make this into a little competition in the MOAs in one office. Maybe that's a bit risky, but how about between MOAs in different offices or in a community, and setting something up like that to say, you know, who can identify whatever, the soonest, the quickest, the most, the best, and post those results somewhere and show trends for improvement or whatever. So lots of different ways of looking at it in there, and not saying that threat of audit or incentivizing with money is wrong. It's the most powerful thing in most cases are those other three: autonomy, purpose, and mastery.
Thanks, Bruce. And I think too, what this, you know, what it speaks to at the end of the day for us, essentially as well is that we need to come up with like a pretty solid engagement strategy for doctors and for MOAs when we do really start to roll this out provincially. So, you know, during this testing phase, we can learn a lot about what are the things that are going to motivate them to, you know, take on this work and start moving it forward. Other questions or comments? All right, well, maybe if there's nothing else this morning, we'll go ahead and end a little bit early and give you guys some time back in your day. I know it's not much time, but a few minutes is always nice to have. So I am curious to hear if you have any other feedback about how today went compared to the last 2 learning labs we've had. I do think we want to find a balance between the two where we're, you know, covering new material and really, you know, talking about our challenges and the approaches and the things that you're running into and that are, you know, the pain points for you out in the field. So we do, you know, we really want to ensure that we're hearing those and figuring out, you know, what else do you need, how else can we support you, what, you know, do you need more communications, documentation, guidelines, tools, changes to the tools, any of that stuff. So, you know, always keen to hear more from you, so please don't hesitate to reach out if there's something else that's coming up. This is a really big change, and I know that for a lot of you who have done, you know, you've just done modules in the past or maybe moved a little bit into the small group learning sessions last year, and this is a big jump that we're taking as PSP into a new space, and it's kind of crazy and it's scary and it's nuts, but we're doing it and we're going to do it together. So I really don't want you guys to feel like you're standing out on a ledge by yourself, because you're not. You know, we're all here and PSP Central is here, and you know, we want you to be supported. So, you know, don't jump over the ledge. Don't do it. The other thing I wanted to mention too, so I know we had a lot of trouble with the WebEx recording from the very first one we had back at the beginning of August. So we had some technological difficulties with that, but we are working with WebEx to get that from them. So Christina has actually been, you know, poking at our ID department and working on getting that back for everyone. So we hope to have that soon, and as soon as we've got it, we will share it out with you again. With that, I think, unless there's anything anybody else wants to add or ask, we will end there.
Thank you.
All right. Thanks very much, everybody. Have a great day. Have a great long weekend.